So now we are going to continue our talk for the MRCS Part A Lower Limb Anatomy MCQ section. So very first we have that which nerve is responsible for the innervation of gluteus maximus muscle. That would be the inferior gluteal nerve. So if we talk about the muscles which are present in the gluteal region, they can be divided into the superficial abductors and extensors and the deep external rotators. Other superficial abductors or the extensors include gluteus maximus, medius minimus along with tensor fascia lata, whereas the external rotators or the deep abductors are the piriformis, superior and inferior gemelli, obturator internus, and the quadratus femoris. Out of these, in this slide, we will be discussing about the gluteus maximus, medius minimus, and the tensor fascia lata, their origin and insertion, along with that, their function and nerve supply. So first of all, our first major muscle is the gluteus maximus muscle. It originates from the gluteal surface posterior to the posterior gluteal line. So on the iliac crust, if we see that this one will be the that is divided into three parts. So we have the posterior gluteal line and we have the anterior gluteal line. Now the muscle which is present posterior to this posterior gluteal line in this region will be the gluteus maximus muscle, and gluteus medius will be present between the anterior and the posterior line. Now this one will be the gluteus medius, and the gluteus minimus that is present over here will be present between the anterior and the inferior gluteal line. So the third line is the inferior gluteal line. So gluteus maximus inserts at the greater tuberosity and the iliotibial tract, whereas the gluteus medius and minimus inserts on the greater trochanter alone. Tensor fascia lata inserts on the iliotibial tract, and that iliotibial tract is specifically inserted onto the lateral condyle of the tibia. Tensor fascia lata originates from the anterior superior iliac spine. Now regarding the gluteus maximus, it is supplied by the inferior gluteal nerve, whereas gluteus medius, minimus, and tensor fascia lata are all supplied by the superior gluteal nerve. Now gluteus maximus is extensor and the external rotator or the lateral rotator, whereas these three muscles are the abductors and the medial rotators of the hip. So 44-year-old man had malignant melanoma. He had block dissection of the groin, and the femoral triangle is being explored for the intraoperative bleeding, which forms the medial border of the femoral triangle. So that would be the adductor longus muscle. So let us revise about the femoral triangle. Now it is bounded medially by this muscle. Now this one is the adductor longus muscle, and the lateral boundary is formed by the sartorius muscle, and the superior boundary is formed by the inguinal ligament. So these are the three very important boundaries, that the adductor longus is the medial boundary, sartorius forms the lateral boundary, and inguinal ligament forms the superior boundary. So the femoral triangle contains this femoral vein, femoral artery, and femoral nerve. Along with that, the femoral branch of the genitofemoral nerve also is present within the femoral triangle. Now, there is an important concept that within the femoral triangle, we have the femoral sheath. As you could appreciate in this green color, this one is the femoral sheath. Now, femoral sheath is further divided into three components: the medialmost component, the intermediate component, and the lateral component. Of the most medial component of the femoral sheath contains the lymph nodes. The intermediate one contains the femoral vein, and the lateral component contains the femoral artery. The femoral nerve is part of the femoral triangle, but it is not part of the femoral sheath. Now, the most medial compartment of the femoral sheath has an extension downward that is known as the femoral canal. Structure which is present at the most superficial aspect of this femoral canal is known as the femoral ring. Now within this femoral canal, or the most medial component of the femoral triangle, not only the lymph nodes are present, but actually it acts as a potential space. Now this allows for the expansion of the femoral vein content when there is a high pressure in the venous compartment. And it also becomes one of the areas for the femoral hernia to develop as well. So 52-year-old female who has post-hysterectomy follow-up, she complains of pain and reduced sensation over the medial aspect of her thigh. Clinically, thigh adduction is weak, so which is the nerve which is being affected? So we have discussed previously that whenever we are going to have a discussion about the nerve, there is going to be some motor function loss and some sensory function loss. So regarding the loss of the adductors and the loss of sensations from the medial aspect of the thigh, that is the obturator nerve. So obturator nerve is responsible for the supply of the medium compartment, that is the adductor compartment, and it contains the adductor longus, adductor brevis, adductor magnus, and the gracilis muscle, and along with the pectineus. Now, as you could appreciate that this median compartment or component of the thigh is supplied by the obturator nerve. So let us take some time to have a review about the rest of the sensory supply of the lower limb. So this lateral compartment or the area is supplied by the lateral cutaneous nerve of the thigh, and this area which is present in the mid portion but superiorly is supplied by the genitofemoral nerve, and this proximal medial portion is supplied by the ilioinguinal nerve. Now in the center, this greenish area is supplied by the anterior and the medial femoral cutaneous nerve. Now the area around the skin of the knee joint and on the medial aspect of the leg is supplied by the saphenous nerve, which is one of the cutaneous branches from the femoral nerve. Now this lateral area of the leg is supplied by the lateral supracutaneous nerve. Now in the lower part of the lateral component of the leg and whole of the sole of the foot except the first web space is supplied by the superficial peroneal nerve, whereas the only sensory supply of the peroneal nerves is the first web space. This sural nerve is going to supply the lateral border of the foot, and the saphenous nerve also supplies some portion of the medial border of the foot as well. So a 34-year-old man is shot in the posterior inferior aspect of his thigh, which lies as the most lateral aspect of the popliteal fossa. So that would be the common peroneal nerve. The most lateral component is this common peroneal nerve, and then we have the tibial nerve, the popliteal vein, and popliteal artery. Now popliteal artery is not only the most medial but also the most deep structure of the popliteal fossa. So bicep femoris forms the lateral boundary, the semitendinosus and semimembranosus forms the medial boundary superiorly, whereas the medial and lateral heads of the gastrocnemius forms the inferior, medial and lateral boundaries of the popliteal fossa respectively. So overall, this is this diamond shaped structure which is present in the posterior aspect of the knee joint. So an elderly man falls and lands on his hip. Hip is tended to palpation and x-rays are taken. And the most likely fracture is the intertrochanteric fracture. What is the normal angle between the femoral neck and the femoral shaft? And that is the 130 degrees. So 34-year-old man had an excision of the sarcoma from the right buttocks. During the procedure, the sciatic nerve is sacrificed. Okay. So what will not occur as a result of this process? So we have to select that which of the function will not be lost. So we know that the sciatic nerve is present in the posterior aspect and it is going to supply the hamstrings over here in the posterior aspect of the thigh and the posterior compartment of the leg as well. So we know that the hamstrings are responsible for the flexion of the knee and extension at the hip. Now this function will be lost. However, the quadriceps which are present on the anterior aspect and are being supplied by the femoral nerve. Now they are responsible for the extension of the knee and flexion of the hip. So we'll be selecting the option that is the loss of extension at the knee joint. So we know that the extension is caused by the femoral nerve and sensation to the posterior aspect is supplied by the posterior cutaneous nerve of the thigh. A 23-year-old man got stabbed in the groin and the adductor longus muscle has been lacerated. Which nerve is responsible for the innervation of the adductor longus muscle? That would be the obturator nerve. So let us take some time and revise all the muscles with their respective compartments and their nerve supply. So in the thigh, it is divided into the front compartment, the medial compartment, and the back or the posterior compartment. So the front is having the sartorius, quadriceps femoris, and the articular genu muscle. Now this anterior or the front compartment of the thigh is supplied by the femoral nerve, whereas the medial compartment, which contains adductor longus, brevis, magnus, gracilis, and pectineus, are supplied by the obturator nerve. This posterior compartment or the back compartment is supplied by the sciatic nerve. So we know that the sciatic nerve divides into two branches, that is the common peroneal and the tibial nerve. So let us see that what specific muscles are supplied by sciatic, tibial, and common peroneal nerve. So semitendinosus, semimembranosus are supplied by the tibial division of the sciatic nerve. Bicep femoris has long head being supplied by the tibial nerve and the short head is supplied by the common peroneal nerve. Whereas the adductor magnus has two parts. The adductor part, which is present in the medial compartment, is supplied by the obturator nerve and the hamstring part is supplied by the tibial nerve. So basically, the muscles which are present in the posterior compartment are known as the hamstring muscles, and there are two things which are very important regarding the hamstrings. They are supplied by the tibial nerve and they take their origin from the ischial spine. So these are the two features that will be found in all the hamstring muscles. So semitendinosus, semimembranosus, the long head of the bicep femoris, the adductor magnus hamstring part is being supplied by the tibial nerve. So 24-year-old lady got stabbed in the buttocks, wound was sutured, and 8 weeks later she had a waddling gait and difficulty with thighs abduction, buttock muscle wasting as well. So which nerve has been injured? So we have discussed that superior gluteal nerve is going to innervate gluteus medius, minimus, and tensor fascia lata. Now there is a specific thing or concept which is associated with this superior gluteal nerve damage, and that is known as the Trendelenburg sign. So how we elicit that? So first of all, we ask the patient to stand on one leg and then we observe for the pelvis. So in a normal patient, the pelvis position should not change on either side. But if there is some pathology, then the pelvis will drag towards the lifted or the unsupported side. So that is the Trendelenburg sign. So if the patient was having normal function of the gluteus medius and minimus, then there will be this normal placement of the iliac crust at the same level. So 76-year-old man presents with claudication and the ABPI is supposed to be measured for this patient. Now signal from the dorsalis pedis artery is auscultated with a hand Doppler device. So this vessel is a continuation of which vessel? So we know that the dorsalis pedis artery is a continuation of the anterior tibial artery. Now in the anterior compartment of the leg, we have this anterior tibial artery, and there is an important concept where it is present between the tib anterior and the extensor hallucis longus. Now it then crosses the ankle joint and becomes the dorsalis pedis artery. This dorsalis pedis artery, which is present over here, is present between the extensor hallucis longus and extensor digitorum longus. In addition to this concept, there is a second concept that this dorsalis pedis artery in the first web space dips down between the two heads of the first dorsal interossei and communicates with the lateral plantar artery to form the arch of the foot. So next up we have a 56-year-old man who had lower anterior resection of the legs in the Lloyd-Davis position. Post-operatively, he complains of foot drop. So which nerve has been affected? We know that the foot drop is associated with the common peroneal nerve damage. Now there are two things which are important with this position. Now this Lloyd-Davis position is used for urology operations, for example, for the prostate and for the urinary bladder. Now, in such a position, if the patient, if when the surgeon is performing the operation and there is some jerky or twitching movement which results into kicking of the foot, in that case, it will be because of the obturator nerve. And if in this same position, which is being in this scenario, is being used for the lower anterior resection, which is a general surgery operation, and the patient presents with a foot drop, in that case, it will be because of the common peroneal nerve damage. Now, why it occurs? Now, in this position, there is specific pressure on the fibula, which is present on the lateral aspect, and if proper padding is not applied specifically in this place, then the fibula bone, specifically its neck, will be put against pressure of the tibia, and this position holding device, and that will compress or damage the common peroneal nerve. So that is the pathophysiology of damage of the common peroneal nerve. So basically you're not going to damage common peroneal nerve in the lower anterior resection, but that is the area where it gets compressed or gets damaged. So 68-year-old man who has critical limb ischemia has undergone femoral distal bypass graft. During mobilization of the proximal part of the posterior tibial artery, which is at the greatest risk of injury. So we know with the posterior tibial artery, we have the tibial nerve that is present. So basically the concept here is that in the posterior compartment of the leg, we have posterior tibial artery. Now this posterior tibial artery is given off as one of the branch from the popliteal artery, which is also going to give the anterior tibial artery. Now anterior tibial artery is going to supply the anterior compartment of the leg, and this posterior tibial artery is going to supply the posterior compartment of the leg. There is a very beautiful concept in the lower limb that with reference to these arteries, there is always presence of some nerve as well. So in the posterior compartment with the posterior tibial artery, we have the tibial nerve, and in the anterior compartment along with the anterior tibial artery, we have the deep peroneal nerve. So it is very important to know that in which compartment, which artery and which nerve is present, because if there is damage to one of the component, it is likely that you will be asked that with reference to that artery, which nerve is being affected for the anterior and posterior compartment, and in the lateral compartment, we have the superficial peroneal nerve, and that lateral compartment of the leg is supplied by the peroneal artery. Now that peroneal artery is one of the branches of the popliteal artery. So how many compartments are present in the lower leg? So we have the 4 compartments. So let's talk about their muscles and their nerve supply as well. So we have anterior, lateral and the posterior compartment. Anterior compartment has tibialis anterior, extensor hallucis longus, extensor digitorum longus, peroneus tertius, and extensor digitorum brevis. And this is supplied by the deep peroneal nerve, and along with that, the blood supply will be from the anterior tibial artery. Now, the lateral compartment contains peroneus longus and brevis, and it is supplied by the superficial peroneal nerve, and the blood supply is by the peroneal artery. The posterior compartment is further divided into the superficial and the deep. So in the superficial, we have the gastrocnemius, plantaris, and soleus. For this, the mnemonic is GPS. And for the deep compartment, we have tibialis posterior, flexor hallucis longus, flexor digitorum longus, and popliteus. Now, these whole posterior compartment, the superficial and the deep, are supplied by the tibial part of the sciatic nerve, and the blood supply is by the posterior tibial artery. So let us have a discussion about the cross-sectional variation which is going to divide these compartments and separate them from one another. So we had the anterior compartment, the lateral compartment, the deep posterior, and the superficial posterior compartment. So this septum is the anterior intermuscular septum. Now this anterior intermuscular septum is going to divide anterior from the lateral compartment, and here this one is the posterior intermuscular septum, and this is going to separate the lateral compartment from the superficial posterior compartment. Then this one is the interosseous membrane, and this one is going to separate the anterior from the deep posterior compartment, and this section is the transverse intermuscular septum, and that is going to separate the deep posterior from the superficial posterior compartment. So the integrity of which muscle is assessed by the Trendelenburg test, that would be the gluteus medius muscle. And the nerve that is affected is the superior gluteal nerve. So this concept is very important. We have had a discussion about this before, and this is just the overview of this concept.